Presenting to you a rare case of a benign epithelial cyst probably arising from the iris invading into the lens. A 10-year-old boy presented to us with complaints of diminished vision in left eye. On examination, his best corrected visual acuity was 1/60. Anterior segment showed what looked like posterior subcapsular cataract involving only the temporal part of the lens, with a suspected posterior capsular dehiscence in that area. Anterior segment OCT showed a cystic lesion involving the anterior lens capsule, the substance of the lens, and the posterior lens capsule temporally. The cyst is seen to be extending into the vitreous, mimicking PC dehiscence. Fundus was within normal limits. The child underwent cataract surgery, the initial steps like any other routine case. Superior rectus brittle suture was applied, conjunctival peritomy done, and hemostasis was achieved with scleral cautery. Sclerocorneal tunnel was made with crescent blade. A side port was made at 2 o'clock position. A continuous curvilinear capsular rhexis was begun after staining the anterior lens capsule with tryphan blue. Rhexis was begun away from the temporal cataractus part of the lens. Almost half of the rhexis was completed with cystotome. As the rhexis was attempted over the cataractus part, the surgeon here is finding it difficult to complete the extending rhexis from the uneven lens surface due to the cystic invasion. Here, the surgeon uses Utrata forceps trying to complete the capsulotomy in the inferotemporal part. Lens aspiration is done and the cataract is aspirated and removed out without disturbing the posterior capsule or the cyst. Following the removal of the cataract, we can see a part of the cyst inferotemporally. The cyst is then inspected and it was found that the posterior capsule was intact over the lesion. The cystic lesion is seen to be moving in the vitreous. With the help of micro scissors, the visible portion of the cyst along with the posterior capsule of the lens in that area is cut and removed. This sample is later sent for histopathological evaluation. A thorough anterior vitrectomy is done. The cyst is not completely removed at this point. The remaining part of the cyst, which lies hidden behind the iris, is separated from the surface of the iris and all the adhesions removed. Its extent is inspected so that it can be removed in toto. The part of the cyst behind the iris is grasped with micro forceps and cut with micro scissors. Anterior vitrectomy is further done. At this point, it is to be noted that The status of the bag temporally and the capsular support is unknown. Therefore, a 3-piece posterior chamber intraocular lens is implanted in the sulcus. After a thorough visco-wash, peripheral iridectomy done with the vitrector at 2 o'clock position. Section closed with nylon 10-0 sutures, 5 sutures applied. Conjunctival closure done and eye patched. Histopathology report revealed that the excised specimen was a benign pigmented epithelial cyst. 1 week post-op, the patient's best corrected visual acuity had improved to 624. Posterior capsular opacification was noted. In conclusion, cysts arising from iris invading lens causing cataract is rare, and those extending to visual axis can be amblyogenic, requiring surgery. This case had a good visual surgical outcome.